Each 40 seconds, one person will have heart attack. Compared with STEMI patients, non-STEMI patients more frequently have pre-existing hidden risk factors: diabetes, hypertension, cardiovascular disease. Despite the higher CV risk in non-STEMI patients, studies have observed they received less aggressive treatment compared with STEMI patients. Reasons why non-STEMI patients may be not treated aggressively, including diagnosis of non-STEMI is less straightforward and may be delayed compared with STEMI. Non-STEMI patients may be less likely to be treated in academic centers compared with STEMI patients. Studies showed that ST depression patients remain at significant risk of dying in the first 6 months after an ACS event, surpassing the risk of death in STEMI patients. Risk stratification studies were performed to study the origin of recurrent events, presence or absence of diabetes, and also the extent of coronary artery disease. Let's take a journey inside non-STEMI patients' coronary arteries. Cadillac study. Cadillac study examined the prognostic impact of the angiographic extent of CAD, showed that non-STEMI patients with multi-vessel disease showed higher 1-year mortality compared to single-vessel disease. Prospect study showed that nearly half of recurrent events in stented patients occur in non-culprit or originally untreated lesions. Among non-STEMI patients, another risk stratification study showed that diabetic non-STEMI patients are at a higher risk of death, both short and long-term, in comparison with non-diabetic non-STEMI patients. Clinical guidelines also recommend a potent P2Y12 inhibitor, prasugrel or ticagrelor, or clopidogrel if they are not available or contraindicated, is recommended before or at least at the time of PCI and maintained over 12 months unless there is contraindication such as excessive risk of bleeding. For your non-STEMI patients, major international guidelines now prefer ticagrelor 90 mg over clopidogrel for the first 12 months.